Chairman, first of all, it is my pleasure to be here and أشكر الأستاذ الدكتور ماهر فؤاد استعنت بيه كتير وما زلت بتعلم منه صراحة بزعجه جدا. الشير بيرسون لو حبيت في أي وقت حضرتك تقول لي اديني ألارم 2 مينت عشان السكيديو لا عشان تلاقي بيه عشان أنا يمكن مش
وأنا لما بقول لها وقت
The topic of today is antibody-mediated rejection, the spectrum. وصراحة I don't know what is the spectrum قصد الأستاذ ماهر فيه وما رضيتش أسأل عشان يبقى الأوبن إن أنا أتكلم عن اللي أنا عايزه بصراحة. معلش الإيميل ده جالي لسه امبارح فأسعدني شوية عشان ما أقدرش أنجح في كل حاجة وأنا بحب الراجل ده طيب سابق عصره. ارضى وابتسم ولا تحدث هذا خير لك. حبيت احطه في الاول. Agenda of this talk is about introduction, definition of acute antibody-mediated rejection, what is chronic, what is late, what is suspicious, what are the differences, and what is the epidemiology of each, and the pathophysiology, and the risk factors, and the precipitating factor, and the clinical feature monitoring, diagnosis, and the pathophysiological basis of therapy, prognosis, management, and take-home message, and last statement. Of course, I'm not expecting to speak about all this, but I'm trying to make it rather complete. Acute renal allograft rejection is a major cause of allograft dysfunction. Some kidneys do not regain function, even with maximal anti-rejection methods. Even among patients who recover, acute rejection episodes have a negative impact. And acute rejection is a major predictor of chronic allograft nephropathy. And the patients are at high risk of cellular rejection are also at a high risk of antibody-mediated rejection. Although the use of potent induction agents may prevent acute cellular rejection in a predisposed patient, these patients may develop what we call it early chronic allograft nephropathy in the old term. And this is an antibody-mediated and not easy to diagnose or to treat. And the beneficial effects of lower incidence of acute rejection are offset by the negative impact of the immunosuppression. The subclinical rejection is when histological changes of acute rejection is observed in absence of increased serum creatinine. And the incidence of subclinical rejection is a highly variable and depends on several factors, include many different things in American Journal of Transplantation 206. What is antibody-mediated rejection? The introduction of those complement C4D staining in renal allograft biopsies, and the sensitive method to detect what we call it anti-human leukocyte antigen antibodies. And the use of these sensitive methods combined with increased number of a transplant in a highly sensitized patient with a donor-specific antibodies or patient receiving these sensitization protocols have increased the awareness and thus the incidence of antibody-mediated rejection. There is a chronic rejection related to this, and I will touch it in a minute, chronic antibody-mediated rejection. And this was illustrated recently. What is the definition? Acute renal allograft is defined as acute deterioration associated with specific pathological changes. And there is two principal histological, as most of the audience know, cellular antibody-mediated, may be difficult to distinguish between, and this is the problem, between acute antibody-mediated rejection and severe acute cellular rejection, even with an eminent pathologist. And however, there are records of allograft with histological manifestation of antibody-mediated rejection in the absence of functional deterioration of kidney function. And this makes a dilemma if you got a biopsy results of this with the kidney function. Just to make it a little bit strict, acute antibody-mediated rejection is a graft rejection caused by antibody directed against HLA molecules, ADO antigen, or endothelial cell antigens. And the clinical rejection is a biopsy confirmed with associated graft dysfunction. And the subclinical rejection is a histological change specific for acute rejection on protocol biopsy or graft dysfunction. And the hyperacute is due to preformed antibodies, and the early antibody-mediated to what we call it amonistic antibody response. The terminology of a late antibody-mediated rejection is a rather recent due to de novo donor-specific antibody production. And the chronic antibody-mediated rejection, it is a recall of a secondary donor-specific antibody response. And we have a mixed rejection and accommodation, which is a resistant to injury in the presence of antibodies. This is adapted from the most recent BANF classification. We are waiting for BANF 2013 in this year because it may have to discriminate different things. I don't have a pointer, so I'll just mention that the main two categories of number 2 and number 4 between antibody and cellular rejection is what? It is a documented antibody may be suspicious with category 3, 4, and 5, so it can be combined but acute. And it is mainly here T-cell. And this one is classified to ATM-like, capillary with capillary margination, and arterial, which actually our pathologist in Egypt most of the time does not mention antibody-mediated rejection, except we find this transmural arthritis. And the T-cell includes, of course, interstitial infiltration, tubulitis, or minimal arthritis. If you discriminate between acute antibody-mediated and suspicious and chronic, the things which I want to emphasize is the presence of C4D. And this is coming from the latest BANF. So if you remove C4D, you cannot diagnose this, which is actually incorrect. So in the acute, there is a neutrophil or lymphocyte capillaritis, thrombosis, of course C4D, and donor specific. And this is a common association. It may not be present, a T-cell mediated or ATM. If you are suspicious, you only found C4D, but find nothing. And the chronic, as we shall see in the picture in a minute, has got a different fibrosis and basement membrane multinuclear. The incidence of this C4D positive biopsy varies significantly between different centers, with a higher percentage in the people who transplant a sensitized patient. And this is with Chapman in American Journal of Transplantation. The terminology of CD4 negative antibody-mediated rejection raised in the last few years, and this will incriminate in the BANF coming. The diagnostic C4D is deposited mainly along the intact endothelial cell layer of the peritubular capillaries in the renal cortex and renal medulla. And actually, we must have a call with renal medulla to diagnose this. And we're waiting for the next BANF to put this in the classification. This picture actually was put in the latest ASN conference. This is a C4D positivity, may have an acute cellular rejection and you got C4D positivity, may have other changes and you can have C4D positivity. You have a chronic rejection with C4D, and you may have even a normal histology with C4D. And our talk is about just a tiny things here. It's a pure antibody-mediated rejection. And if you see this figure, you may have a donor-specific positivity in the serum, but the C4D is negative. And you may have, on the other hand, a C4D positive and this donor-specific negative. And the classical picture here is not 100% found. That's why the BANF in 2011 have a controversial diagnosis of the role of C4D as antibody-mediated rejection. And they put certain context to be clarified maybe this year as a negative C4d, as a non-conflict fixing antibodies, there may be a clearing of C4d. What is the actual definition of the positivity? Is it focal or diffuse? And what is the relation between staining inflammation if atrophic areas does not change? And the different phenotypic changes between different graft function. So, going to the epidemiology, we find, of course, as acute cellular rejection incident decreased, however, graft and patient survival do not match this progress. In 1980, actually we have about 60% here acute cellular rejection coming in 2009 to become only 10%. And in the antibody-mediated rejection, depending on the type of the pathology, and this is coming here, we have, if you do that in the protocol biopsy in 550, we have a diffuse about 2.4 and focal 2. And if you done it in an indicated kidney biopsy, you may find the diffuse is a little bit 12% versus 8% in a focal. So this is the increase, a little bit of antibody-mediated rejection. Many, although not all studies have demonstrated association between subclinical rejection demonstrated by protocol biopsy and decreased allograft survival and or function. An example in this study with 400 protocol biopsy, it showed that subclinical rejection with this positivity may be affecting the graft survival. And another study with 800 and 300 clinically indicated biopsy found the presence of interstitial inflammation in the subclinical rejection, whatever the cause of it. And the significance of this subclinical C4d staining in relation to chronic antibody-mediated rejection is even still not clear. And the past long time ago changed the antibody-mediated rejection to reflect the finding of C4d. Now they're thinking that C4d by itself may not be important to diagnose. It is unclear if the administration of therapy to patients with this will help the patients. The pathophysiology, in short, starting from this lymphoid stem cells till we have the CD20, and it is related to our allele here. And if you donor organ capillary endothelial cell in the formation of antigen-antibody complex, and this causes damaged cell and release of platelet aggregation factor and C1 complex going to C4d. And this causing endothelial cell necrosis. And the C4d is this byproduct and marker of complement activation. And this is Bashwas in New England Journal 2010. Most patients have acute rejection episodes are asymptomatic. This is the problem. However, occasionally patients with different non-specific complications and hypertension and other manifestations. And laboratory manifestation with acute allograft rejection with an acute rise in serum creatinine, but this rise is a late development and in the course of rejection and may indicate the presence of a significant histological damage. Pyuria or leukocyturia or a new worsening of proteinuria may also be present. And the radiographic manifestation is also non-specific, and we may rely on a resistive index, but actually this has no absolute figure to decide if it is high or low. It is related to the patient himself before that. And the monitoring of this acute rejection, including many different things, but often there is a significant histological damage that may be partially irreversible by that time. And most clinicians follow the blood pressure and urine protein excretion. Immediately after surgery, this may be depending on the time to follow your patient according to different protocols of rejection. And patient reported his vital signs either in a different schedule, and he may be at increased risk, so that the methods of determination of this will be more frequent. What about protocol or surveillance biopsy? These authors do not perform protocol or surveillance biopsy unless required for a clinical trial. And the term surveillance is preferred since it implies clinical and reimbursable reason for biopsy among patients with delayed graft function or at a high risk of acute rejection. And the rationale of performing surveillance biopsy is that they are more sensitive than serum creatinine for detecting acute rejection. But look to this, up to 30% of protocol biopsies showing evidence of rejection among patients with a stable renal function in more than one references in the KI 2007. And although these surveillance biopsies are in general safe, but the risk of major complication is present, and acute rejection often a patchy process, so adequate cause must be present. And the utility of this surveillance biopsy is still not clear, since there is no conclusive evidence that the treatment of subclinical rejection improves long-term outcomes. I am not debating some studies which show otherwise. So, this is a picture of antibody-mediated rejection, and we have 4 different things. This is the C4D staining in the peritubular, and we may have a picture of ATM or a picture of glomerular region has got what we call it follicular deposits. And in the latest stage, and actually that's what I used in Egypt, is you must have an artery with a small artery branch and a transmural fibrinoid changes. If you go to the chronic phase, you may get a double contour, and of course we know more than one cause for this double contour, but actually the most important of transplant glomerulopathy is this double membrane, basement membrane multi-layering of this. So to transplant, the chronic phase of transplant glomerulopathy can occur any time after transplantation, very early, and induced by transplant glomerulitis, and it has a 20 to 50 only of C4 positivity, and approximately 60% associated with chronic vascular changes, and slow rise in proteinuria, and no specific therapy, and poor long-term graft outcomes. So it has a peritubular capillary basement membrane multi-layering with a chronic allograft arteriopathy. So this item is actually raised in New England Journal 2010, chronic antibody-mediated rejection. Antibody-mediated rejection can occur not only in the kidney, but actually in different ways. Of course, in the kidney, as we mentioned, has got these difference, but in the pancreas, you may have acute antibody-mediated rejection, and they have a suspicious if you find 3 out of this, and 3,4-D in one of the this American Journal of Transplantation. In the heart, you may have an acute antibody-mediated rejection in the heart, may include donor-specific antibodies in their criteria. In the liver, and the lack of clear criteria for diagnosis, and even in the lung. And the antibody-mediated rejection with this positivity of peritubular capillaritis or the peritubular C4D staining in immunofluorescence and immunohistochemistry. And there is a debate between the Europe and the America what to use best. And this is a different picture of the staining of the immunohistochemistry of the C4D. What about the prognosis? Remain the questions. How much % success rate as a graft survivor or patient survivor once antibody-mediated rejection diagnosed? And how much % graft failure and patient mortality will affect? And this coming from indefinitely, this antibody-mediated rejection causes vasculopathy, fibrosis, and loss of graft function and graft loss. But this appeared in this JSON in 2010, which shows by measuring the anti-HLA donor-specific antibody present or not, and even the class, or actually even its presence, or the full-blown picture of antibody-mediated rejection, that the graft survival will decrease after 72 months. And actually, if you find even anti-HLA donor-specific antibody, it decreases. But the full prone picture will affect the prognosis. And this occurred also in the American Journal of Transplantation just a few months ago. And it shows if you find a donor-specific antibodies, this will decrease without even in the period of 11 months. So what about the treatment? The treatment has 4 important different things. Suppression of T-cell response, elimination of circulating antibodies, inhibition of these antibodies, suppression or depletion of the B-cell. And if you have a suppression of T-cell, remember that this is antibody B-cell related, but the suppression of T-cell response is an important issue. And this is by depletion of anti-lymphocyte antibody by ATG and has a multiple anti-C, anti-T-cell antibody specialty, and usually use an adjuvant treatment, not the main treatment, and have a severe or strict resistance steroid anti-cellular rejection, and it is FDA approved. The steroid can be used because it inhibits more interleukins. The MBA prevent proliferation, and the FDA approved for that, and CNI post-cyclosporin tech inhibit both T and B cell activation and proliferation. And if you go to the elimination of circulating antibody, which you may think this is the main treatment, is plasmapheresis, and is fast and effective but temporary. It must be in combination of other therapy, and they have a different adverse effects. And the dose is depending on many protocols, including every day or every other day for 3 to 6 treatment by 1 to 1.5 total plasma volume. Of course, if you increase more plasma volume, you have more complications. And decision to stop this plasmapheresis should be based on the measurements of this donor-directed HLA, establishment of good graft function or a graft failure. And the cost in US is around $2,000. Apheresis guidelines consider a therapeutic option when antibody-mediated rejection has been confirmed by biopsy and/or positivity of donor-specific antibody immunosuppressive probe has not been effective. So this is the approval phase. And this is in 2009. What about inhibition of the antibody? And this may be inhibition mainly by IVIG, which is a purified immunoglobulins, and the action is by immunomodulatory on the T-cell macrophage and cytokine. Down regulation of this antibody and both T and B cell, but there's adverse effects and a hypercoagulability reaction. And the dose may be ranging from 100 milligrams to 2 grams per kg, and of course the cost is a little bit high. What about suppression of depletion of B cell, which is the main mechanism? And this is coming from rituximab, genetically engineering, and indication by FDA approved in a non-Hodgkin lymphoma, and the action bind to the CD20, which mentioned in the Pathophysiology, and it depletes CD20 and 19 and no effect on the plasma. And we have adverse effect, and the dose is 375 per square meter surface area, but actually the duration of treatment is not settled. What about depletion of the plasma cell itself? And this is my Pathophysiology, which is a reversible proteasome inhibitor, and it is approved for multiple myeloma and used for antibody-mediated rejection off-label. And the dose is from 1.3 to 1.5, and we have different adverse effects. And the University of Wisconsin experience in liver and kidney and pancreas, as it will show in a minute. And the complement inhibition, this is the 6th category of treatment, is by glutamate. And this is a recombinant humanized monoclonal IgG, and indication mainly for paroxysmal nocturnal hemoglobinuria and atypical HUS. And we have a lot of adverse effects, and the Mayo actually used this, and the dose is 600 milligrams intravenous every week or every 2 weeks, and the duration as the rituximab is unknown. We must monitor during the treatment the graft function, the infection, the viral or bacterial, the bone marrow suppression, leukemia, thrombocytopenia, donor-specific antibody, and other immunosuppression, and repeat the biopsy. What about prevention? Identify who is at risk. This is important. Sensitize with a current PRA more than 20 or the peak more than 50. Black race, female, transplant, positive cross-match, certain disease status, and caution with minimizing immunosuppression, and monitor donor-specific antibody, biopsy, and organ function. This is actually one of the protocols coming from University of Wisconsin, and they actually depending here about, we have a grade here, and we have early or late. The early or late. You have a grade here of what is grade 1 PANF or grade 2 PANF, repeated over C4D positive more than 50 or less. And if you have, for example, a late, you may have a dexamethasone with scattering with IVIG weekly for 4 weeks. And if you have a late with a C4D more than 50, you must have an IV in the same protocol, 100 milligram. It depends mainly about combination of dexamethasone and IVIG and plasmapheresis, depending on early or late if you encounter. But actually, to finish this up is the KDUPI guideline, and actually it has only 2 seen evidence. And they said, we suggest treating antibody-mediated acute rejection with one or more of the following alternative, with or without corticosteroids. Plasma exchange, IVIG, anti-CD20 antibody glutamate, or lymphocyte depleting antibodies. But still, we have this chronic antibody-mediated rejection, we have the mixed rejection, we have what we call it refractory acute antibody-mediated rejection. Mr. Chairman, my take-home message is antibody-mediated rejection can occur at any time. Biopsy confirms the diagnosis due to preforming antibodies, memory response, or de novo antibody production. Causes vascular injury, fibrosis, which lead to decreased long-term graft survival. Can be reluctant to treatment, and they increase so much the infectious complication after treatment. And my last statement is, in absolute terms, antibody-mediated rejection can be diagnosed and may be treated, but we have a different antibody-mediated reaction, which is a chronic or the later suspicious. However, this C4D, the gold standard we think for the diagnosis, may not be as good as a cause-effect relationship. That's why the PANF in 2011, waiting for 2013, hence still it is better to prevent rather to diagnose and to treat antibody-mediated rejection. Thank you very much.
Thanks to Ahmed for this excellent presentation. So I just have to add, دلوقتي البروتوكول biopsy ده عشان في سب كلينيكال انفكشن او سب كلينيكال رياكشن هتشيل ازاي يعني؟ يعني احنا هنعمل البيوبسي
هو في صراحه معلش ماي بيرسونال فيو، وهي طبعا مالهاش يعني لازم اقول بالنسبه للناس اللي بره، البروتوكول بايوبسي has no role except in our research. But they claim there is a discrepancy between the literature, between some data showing that if you find something as subclinical rejection by protocol biopsy, you must treat and treat aggressively, and they claim that this will help the graft survival. Some other papers do not find the same results. But the protocol biopsy is different than indicated biopsy, of course. And then لا هو حسب السنترز اللي في امريكا، في بعض السنتر بيعمل بروتوكول بايوبسي حسب ما هو مرتب، ملوش دعوه هو العيان كويس ولا وحش، لو كويس هتدخل من البروتوكول بايوبسي الانديكيتد بايوبسي. عشان كده الفرق في الداتا اللي شو indicated biopsy has positivity of donor specific antibody 12 و8% فيرسس البروتوكول 2%. وحتى دلوقتي الكلام عشان كده البانس بتاع 2011 دي مش بانس، ده كان ميتنج قال انا السي 4 دي انا مش عارف احتمال ما تبقاش ولا حاجه، ما عالجهاش، يعني هي في الكونتكست لوحدها ما تعنيش شيء. عشان كده لسه الثاني ده من 7 ولا 2007 2009 لغايه 2013 لسه في الوقت، لكن ما بيعملهاش الا كبروتوكول ملوش دعوه بالبيشنت.
شكرا دكتور احمد على المحاضره الجميله دي، والكلمه الهائله اللي انا ما نديش اهميه للسيمبوزيوم. في موقع من دول عماله تزق السيف ويجي ان هو زي كل فولترز اكشن لوحده بدون عدم استيميشن بدون سبيسيفيك انتيبوديز.
طب حضر لي اسئله كتير يا باشا. ايوه ماشي. ايوه
هو بقى يا باشا النقطه اللي انا عايز اقولها ليه يعني عشان السي جي برضه انا فضلت مش اهميه.
ايوه انا ما قلتش كده،
هو 3/4 لازم السكور 3/4 اللي هي كرياتينين يعمل باثولوجي اوكي دولار سي 4 دي فالاربعه دول 3 منهم بيبقى كفايه. حاجه ثانيه السؤال مثلا لو مش متقسمه ليه بيبقى موجود في البيت تريبلر بس سي 4 ليه مش موجود في البيت؟
لا هو اللي انا ما اعرفش هو ليه، لكن اللي متاكد منه لو هو جلوميرولس، معلش انا هرد على الحته دي، الحته اللي انا فاهمها. لو هو جلوميرولس سي 4 دي does not mean anything, it is not in the protocol، لكن لازم يبقى فيري كيوبلر. اشمعنى بقى فيري كيوبلر؟ I think لو حضرتك الباثوفيسيولوجي هو في الاخر بينتهي بايه؟ باندوثيليال سيلز. الاندوثيليال دي موجوده مينلي يعني في البيت كله.
ايوه هي المشكله مش في كده، يعني لو مثلا واحد بتاخد بايوسي دايما بتتمنى ان هي تبقى كورتيكال.
لا دي مصري مضلة.
دي بالذات لو طلعت مضلة
حاجتين لازم يبقى مضلة.
ما ردتش على السؤال.
السؤال ارد عليه يا باشا.
هترد.
ايه هو في البلوميرماس وفي الميريكولار كابس الريسبتورز في انتي بوديز ليها. الانتي بوديز اللي في البلوميرماس النيوتراليزر. الانتي بوديز دي مش موجوده على الميريكولار كابس فبتقبل بس من الصبغه لكن ما تقدرش تعملها.
لا جنس الكلام ده حاجه واحده، لان احنا بنلاقي جلوميرولار ديبوزيشن سي 4 دي في الجلوميرولار ما نحطهاش في الكراتين. كلام حضرتك يبقى معناها ما لقيهاش، ولا لا بنلاقيها وبنلاقيها في الانترسيشن.
بكلمني عدد الريسبتورز، يعني ايه حاجه هنا في 100 ريسبتورز وهنا في 10 بس، لا هنا هيبقى في برضه.
انا هكسبت كلام حضرتك بس الفكره ايوه لو لقينا سي 4 دي ده اللي فاهم حضرتك صح. لو سي 4 دي بوزيتيفيتي في الجلوميرولار has no impact
خالص.
ايوه فمعنى كلامك واحنا بنشوفها ساعات معنى كلامك
ليه في انتي بوديز نيوتراليزنج لا في المنطقه دي مش موجوده في البري تريبلر، يعني هي في الجلوميرولار سبحان الله 4 انتي بوديز نيوتراليزنج في المنطقه دي
بس ليه؟ انا ما اعرفش الغلط، لكن ليه هم اصروا على البيري تيوبلر؟ انا
هم اللي اصروا ما فيهاش انتي بوديز.
ما مين احنا بقى او احنا اصرينا؟
انا قبل ما الدكتور عايز يسال على حاجه بس انا هقول كلمه واحده ثانيه في الترانسبلانت بايوبسي. الحاجتين اللي انا عارفهم اللي لازم حد يزود لي حاجه ان لازم تجيب مضله هو الانتي بودي ميديت ريجكشن، والحاجه الثانيه البوليوم
والاوكزالوزس.
اوكزالوسيس في الانترستيشن ممكن، لكن انا بتكلم على المضله. لازم تلاقي في البيول تبقى مضله، يعني لو ما ينفعش تقول انا رود او بوليوما without مضله.
برضه احنا بنتكلم على ليه قالوا
عشان
بس المسج الناس اللي قاعده ايه يقول لنا
ان معظم السيلز المسؤوله عن الفاسكولار سبلاي اللي هي اساسا are the pericytes which are present mainly in the
لا دي واحده ماشي. ما هو لو هو ده الكلام كان لو ظهر في الجلوميرولار ايوه، لكن هو لو ظهر في يعني عشان على الكلمه دي لو ظهر الجلوميرولار اونلي I will not take care of it. هي سمعنا اصلا طب الميكروفون ولا بس
شهور من الكلام اللي قلته
حاضر
دوروا عليها.
حضرتك السيمبل بروفيشن بريكيولار كاتينري بريكيولار كاتينري الانيشال ده باثوجينيسيس بتاع الانتي بودي ديترمينيشن. ده الفيرست step in the backward circulation of the brain of the brain tubular capillary. And here the endothelial line is the site triggering the sequence.
انا مش معترض على حضرتك، انا عارف
بس
لا لا. طب انا معلش انا هجيب حسن بس عشان افهم. انا عارف ان الاستاذ ابو طب لو لقيت سي 4 دي بوزيتيفيتي في الجلوميرولاي
وده سي 4 دي بوزيشن in the glomerular capillary is not as rely on rejection.
ايوه
it has relation to the poor graft alveoli.
طب جميل. ما ده ايوه ده against what you are saying. You are saying that this peritubular plate is more sensitive، او هو ده السايت اللي بيحصل فيه سكر. ثانيه واحده بس، ما هو دي نقطه انا موافق على دي، بس في حالات كتيره بنلاقي جلوميرولار بس. ايوه
we not rely on this.
ايوه يبقى معنى كده ان ده مش يعني
ايه في التيوبر كابيلاريز بيخليها سبيسيفيك؟
ايوه انا هقول لك كده بس
لا بيقول لك
هو فيها حتتين، واحده منها ان هي دوز ريليتد اوف الانتي بودي ميديتد ريجكشن، هو موجود في الاثنين الفيروس والكابيلاري. لما بيكون في اوفر فلو من الانتي بودي تتر فلازم يبتدي يظهر في
صح، عشان في نيوتراليزنج في الجلوميرولار.
انما ما فيش سي 4 دي كابيلاريز من غير جلوميرولار.
الاثنين موجودين كمان. لما يكون في الجلوميرولار ده ملوش دعوه بالانتي هو ممكن الكلام ده مع لا ممكن وممكن لا. يعني اقصد ان السي 4 دي فانكشن مايت بي ريليتد لاي جلوميرولار فراكس ثانيه، انما مش لازم يكون انتيبودي ريجكشن. اي اندوثيليال رياكشن يمكن نوع الاندوثيليال بيفرق شويه صغيرين، بس اي دونت نو. فاللي انا فاهمه ان هو الاوفر فلو والتتر العالي يبتدي يبان هنا ويبان ليتر اون في الكابيلاري.
Thanks, Professor Ahmed Adam. We are getting time. Now we shift.